Everybody. It is my pleasure to invite all the delegates to IMA KSB and program on impending COVID third wave. So this is the fifth series. The program will be held on every Wednesday evening by around 7 p.m. and by around 9 p.m. And at this juncture, I invite all the delegates. I appreciate the presence of IMA KSB office bearers, Dr. Suresh Kudwa, the President-elect IMA KSB, the Secretary. Okay. The IMA KSB State Honorary Secretary, Dr. Prasad sir, the Treasurer, Dr. Karunakar sir, immediate past President, Dr. Madhusudan sir, and the academic subcommittee member as well as the women's wing member, Dr. Geeta Dappa madam, all the delegates, the past presidents, the state working committee members. So this is an ongoing program by the IMA KSB subcommittee. So this is to enlighten the members, the postgraduates as well as the students. And we also conduct some program for the general public as well. Today, we have two renowned speakers with us. Dr. Lalita A.V., Professor and Head of the Department, Pediatric Intensive Care Unit, St. George's Hospital, Bangalore. We welcome you, Madam, to the webinar.
Thank you so much.
It is also my pleasure to welcome another speaker, Dr. Mahesh P.A., Professor, Pulmonary Medicine, JSS Medical College. I welcome you, sir. The first speaker will be speaking on severe COVID-19 infection in children. Before that, I request Dr. Karunakar sir to moderate the program. Thank you.
Thank you, sir. Thank you so
Before
much.
that, before that, it is my pleasure to welcome our President-elect, Dr. Kudwa sir. I don't know whether the President has joined already.
He has joined already.
Oh, he's there, Dr. Okay. It is my pleasure to welcome our beloved President, Dr. Venkatachalapati sir, to the webinar, and I request the President sir to speak a few words. Thank you.
Good evening, everybody.
Yeah, you are audible. Yeah.
Good evening, everybody. President-elect Dr. Kudwa sir, IMA KSB Office Bearer Secretary Dr. Prasad, Treasurer Dr. Karunakar, Subcommittee Chairman Dr. Harish Delantabettu, and today's experts who will be delivering their lecture, all the other delegates who are on this Zoom platform. Indeed, it's a very proud moment for IMA KSB because when there was a lot of confusion amongst our members regarding the third wave, and most of the members who were following the WhatsApp were getting confused what to do, what not to do. So that was the time when IMA Karnataka State Branch took a bold decision, and we thought of starting a series of webinars, particularly on Wednesdays, inviting experts in the field of COVID care and particularly seeing the threat of third wave. And in fact, I should place on record that for the past 1 week, I have traveled all over Haveri, North Canara and Dakshina Kannada. And wherever I have gone, there was a wonderful response. They've all appreciated our initiative of helping our members to get an authentic information from experts. So this is a wonderful program. I'd like to congratulate all my colleagues without whom this program wouldn't have happened. And this is not the end. Still, these programs will continue every Wednesday, and probably another 4 or 5 webinars we'll be holding. So without wasting much time, I have to hand back my mic to Dr. Delanta Bettu to carry forward the further proceedings. Thank you so much.
Thank you, sir. Thanks for joining in spite of your busy schedule. And we appreciate all your activities and traveling throughout the state and giving assurances and strength to our members. And we are very grateful for your work. And it is a great job indeed. Thank you for joining. May I request Dr. Karunakar sir to moderate the session.
Thank you, sir. Thank you so much. Respected President, sir. Past President Dr. Madhusudan is also there. Our President-elect Dr. Pudva sir, Dr. Lakot sir, and Dr. Prasad is there with us, and Dr. Harish is the backbone of this program. All our past presidents, office bearers, and wonderful members and the viewers who have been supporting our initiative to learn from the expertise of our experts. It's been a wonderful session. We have been able to bring in good speakers and good topics have been covered. So today we have another 2 important topics. Again, one is on pediatrics, because we are expecting possibly third wave is going to be having a significant impact on pediatric population. So we are trying to see how best we can educate our members on pediatric aspects, so that there must be certain amount of confidence in managing and even referring this patient. So we have regularly one session on pediatrics, another session on adult COVID-related issues. Today we have the first speaker, Dr. Lalita. She is the professor and pediatric intensivist and head of the pediatric ICU at St. John's Medical College. She is running one of the most active and vibrant pediatric intensive unit, a close friend of mine in the professional circuit and also in our academic activities. She has many credentials to her in terms of her publications, presentations, research activities, and she has been doing extraordinarily well. And she is going to share with her experience of COVID-19 critical care patient from St. John's Hospital. And then we have second speaker we're going to introduce afterwards. Friends, I request you to really listen to Dr. Lalita's presentation, and there must be a lot of questions for you regarding what is happening to pediatric COVID cases. I'm sure she is going to help us clear most of our doubts with this one. I would like to express sincere thanks to the IMA KSP President and all the office bearers, and I also welcome everyone of you to today's meeting. And I'll request Dr. Lalita to start today's meeting actually. Dr. Lalita, it's over to you now.
Thank you, sir. Thank you for your kind words. Yeah. Thank you, sir. Good evening, all. First of all, at the outset, I would like to thank for this wonderful opportunity to the IMA branch, the president-elect, the secretary and the committee members. Special thanks to Dr. Karunakar sir, my mentor, and as well as one of my close friend. We do have a lot of interactions, and sir gave me this opportunity. Special thanks to you and all the viewers. So today my topic is severe COVID infection in child. So the learning objectives are divided into 5 learning objectives. We are just going to look at COVID-19 disease, which is not new. All of us are pretty well studied, well aware of COVID-19 disease. Severity classification when it comes to a child with COVID infection. What investigations are we going to do? How are we going to manage respiratory wise, and general supportive and drug treatment? So COVID-19, though it was discovered in 2019, though it is called novel coronavirus, I think all of us are familiar with this coronavirus infection, which predominantly affect respiratory system with manifestation ranging from simple URI to full-blown ARDS. And it is very, very important for us to recognize the risk factor, the category, severity, and provide early treatment. And as earlier said, this COVID-19 has posed critical challenges for all the researchers as well as medical community. And most of the data has come from adult, and very sparse data has come from pediatric. However, we do share a study, WHO study happening at St. John's Hospital. And we are familiar with the symptomatology of COVID-19. Just a brief overview. When to suspect COVID-19 in a child? If a child, they do come with fever, headache, myalgia, fatigue, upper respiratory tract infection. Predominantly, we have seen children coming with GI symptoms like diarrhea and vomiting. And small children, we can appreciate if the child is symptomatic, they can come with poor feeding. And not to forget MISC case. I think we have flurry of MISC case during COVID and post-COVID as well, where children do come with high-grade fever, rash, conjunctival congestion, and mucositis. And do remember that many a times in children it is asymptomatic, but it is just a history of contact will be there. So with this, the learning objective will move on to severity assessment. And my slides are predominantly from IAP and the Government of India Ministry Welfare. They have divided the severity assessment as mild, moderate, and severe disease. Mild is just simple URI symptoms, just something with fever, sore throat, rhinorrhea, cough, and diarrhea. Moderate is any child who present with fast breathing. Fast breathing. Based on the age, we do know the cutoff, different age group cutoff for fast breathing. Less than 2 months, 60, 2 to 1 year, 12 months is 50, and more than 1 year is 40. And with the presence of hypoxia, that is saturation between borderline, around 90 to 93% on room air, and there is no evidence of severe disease. So when do we say severe disease? Any child with pneumonia, with any of these following, like if the child is not maintaining saturation at all, has got increased work of breathing, and has got grunting or retraction. And if in this case, if it is just child present with lethargy, seizures, GI symptoms causing severe dehydration, we call it a severe disease. And there is some subset of severe disease we call critical disease, which is defined as any child present with ARDS, shock, multi-organ dysfunction, or acute thrombosis. So if you look at this clinical presentation, what as we can see is majority of them either mild or asymptomatic. Around 50 to 60% of them can have some mild symptoms, little fast breathing, or about 20% uncomplicated. As you can see here, only less than 5% of them do come with severe pneumonia, and with this less than 1% develop with ARDS, septic shock, or severe infection. So having known about this mild, moderate, severe disease, which is very, very important, this is again based on the WHO classification, I would like to take you through some of the case scenarios. Okay, this is a child. The first case is a 7-year-old girl who present with the OPD with symptoms of fever, upper respiratory symptoms, and parents were COVID positive. And one need to assess the initial impression. This is a non-touch technique. All of us are familiar with pediatric assessment triangle. When appearance, the child is active, playful, work of breathing is normal, and circulation is pink. Sorry. So on examination, this child, the respiratory rate is absolutely normal. As we can see, the vital examination is normal, maintaining saturation, and temperature is normal. Severity classification, it is mild disease. What one need to do with a mild disease is just nothing but symptomatic treatment. Majority of our patients are just history of contact with COVID or COVID positive, and generally they are mild disease which can be treated at home or on an OPD basis, but make sure you give a proper advice like taking plenty of oral fluids. If there is any fever, then paracetamol, plain paracetamol, or if there is any nose block, saline drops. And remember, there is no need to investigate mild disease at all. But some advice is very much required, something like maintaining monitoring chart, counting the respiratory rate. So ask them to look out for danger signs. If their child has got tachypnea, persistent vomiting, high-grade fever, so ask the parents to have a watch on the temperature at least twice or thrice a day, or whenever the child is having fever, if the child is having fast breathing or not feeding well or decreased urine output. So all that this child with mild disease is required is home isolation. The second child, this is a 3-year-old child, came with fever of 4 days, mild cough, but she started to having mild fast breathing. Otherwise, pediatric assessment triangle, she looked well except for mild increase in the tachypnea. As you can see here, the vital signs, here you can see the child is tachypnic, 56 per minute. Otherwise, hemodynamically she is stable. Saturation is just borderline and temperature is around 99. So as you can see, this child is moderate, in a severe moderate infection because she is tachypnic. Otherwise, no other features of severe infection. So what one need to do is just because she's not maintaining saturation, make sure please start with oxygen. These children do require admission to a COVID ward. So start with oxygen, start with initial IV intravenous therapy in case the child is not taking orally. Watch out for high grade temperature. If necessary, give paracetamol. Generally, corticosteroids are not indicated for a mild to moderate disease, but in late phase of moderate disease, definitely we need to consider this corticosteroids. So this is a third case. The 11-year-old girl, this child presented to us with a high-grade fever on day 6, day 5, had some amount of vomiting, poor feeding, and she was quite tachypnic. So we started on NRBM and saturations were 93%. And as you can see, she has got all the features of this red flag sign. She has been febrile since last couple of days. She is tachypnic and she's not maintaining saturation, though she was quite alert, but she was not taking orally well. So this child has got all the features of severe disease because she's tachypnic, tachycardic, though hemodynamically stable and not maintaining saturation. So one need to diagnose or recognize early severe disease based on these findings. And when we saw this X-ray, this was showing bilateral opacities. As you can see, the case 1 was just asymptomatic or mild, case 2 was just moderate, and case 3 was severe. Why is that? Some children, majority of children, COVID infection in children is mild to moderate, very rarely, around 5.2 to 6% rarely progress to case 3. This is a girl, the same girl which I was talking about, who was not maintaining saturation and we had to connect to NIV. So before we move on to, why this child has got severe, one need to understand the pathogenesis. And this is very, very clear. Thanks to a lot of studies, a lot of publication has come up from last year. There have been flurry of papers which is telling about, which is mentioning about the pathogenesis. So as we can see here, SARS-CoV infection, mainly it attacks the ACE2 receptors and TMPRS2 receptors. And there is an active replication which happens with the viral causing pyroptosis. This is the early host response and later on pathogenic host response. Initially what happens is a physiological host response where after SARS-CoV infection, the ACE2 receptors, it blocks ACE2 receptors, then there is immune cell involvement, and finally the host physiological response will try to kill all this virus by producing a lot of pro-inflammatory cytokine and chemokine release and elimination of the infected virus. So the case 1 and case 2 had this physiological host response. As you can see, the case 3 went on to pathogenic host response where there was a hyperinflammatory state, what we call very well described as cytokine storm, and causing involvement of the organ failure. So where there is excessive infiltration of the immune cells in the lungs, systemic overproduction of the pro-inflammatory cytokines and aberrant regulation, there is an imbalance between pro and anti-inflammatory, and finally leading to multi-organ dysfunction. So one need to be very, very vigilant, especially in mild to moderate cases. Now, when these children can transition from mild to severe cases based on their immune response, generally around 5 to 7 days. So this is again a graph depicts the various viral load and inflammatory response in the various category of the disease. As you can see, the viral load is very, very minimal and the inflammatory response is just modest in case of mild. Moderate disease, it goes on from starting from day 1 to day 7 and it sort of subsides. But some children like, the case 3 who presented with, mild but rapidly progressed day 7 onwards to very severe disease, and she presented with septic shock, BIC and almost MIC and HLH like presentation. So this goes on till day 16 of the illness. So one need to understand the difference of COVID pneumonia versus bronchopneumonia due to other bacteria. As you can see, there's a large lung surface which is involved in the COVID pneumonia than due to bronchopneumonia due to other virus, basically due to ubiquitous expression of ACE2 in the type 2 pneumocytes. But one very good thing, fortunate thing in children is The AC2, many studies have shown AC2 receptors are very, very minimally expressed in children, not much developed, and because of the live attenuated vaccines, which these children like measles, MMR, in children, the severity is very, very less. Unlike bronchopneumonia due to other bacterial etiology, where you can see it predominantly affects the bronchial tree, whereas in pneumonia it predominantly affects the peripheral lung field. Almost the entire lung can get involved, but involving the subpleural and peripheral areas. So lot of lung damage happens because of the cytokine storm. There can be diffuse alveolar damage and inflammation, interstitial inflammation, macrophage activation syndrome like thing, and the activation of innate immunity and microthrombi because of age-related coagulating cascade, which is very well studied in adults. So having known with the severity, let's move on to what investigation should we consider in a child with severe COVID pneumonia. So we are all familiar with this timeline of this COVID infection. This day 0 is when the symptoms starts. So prior to day 0, when during the incubation period itself, around 14 to 20 hours, we can see that there is an increase in viral load and the patient can be very, very symptomatic. So this is the phase when we can see the rapid diagnostic test, something like antigen test can be positive. If we do probably -1, and it may not be positive beyond 5 to 6 days, whereas your molecular test like PCR can be positive -1 and it can be continued to positive for weeks together. So one need to choose which test has to be done in these children. So antigen test, suppose if a child presents on day 7, usually it can be negative day 5 to day 7 onwards. So please consider to do molecular tests like RT-PCR test, which is a viral genetic material, which is very highly sensitive and highly specific. And after 1 week, there is a mount on immune response, and you will be able to detect IgG and IgM antibodies. Especially we do reserve IgG or IgM antibodies for MIC patients. So something I thought I would highlight on CT ratio or cyclical threshold. So cyclical threshold is nothing but a semi-quantitative indicator of the concentration of this viral. Basically, it tells the number of cycles which is needed to amplify the viral RNA. Something which we need to remember is low CT value indicates high viral load and high CT value indicates low viral load. So the clinician or how is it relevant to a clinician or the patient perspective? Whether low CT value is good or high CT value is good. Generally, no studies have been done to validate about the CT values, but it mainly tells about infectivity. So if it is a low CT value, it is they are the one who are highly infective, whereas high CT value, they have got low viral load, but this happens during the late phase of the disease, and it doesn't indicate that the disease is very mild. Many a times we do have children with high CT value and has got progressive pneumonia. So something, if the CT value, if the patient comes and asks about the CT value, it does not got a clinical relevance unless you do repeated CT values. So next laboratory, what are the other laboratory investigation one need to consider in COVID-19 infection? I broadly classified into COVID-19 infection, co-infection, organ involvement, and inflammation. So coming to COVID-19 specific, which we already discussed about RT-PCR, rapid antigen test, and antibodies. And the next is co-infection. What we have seen is of late, we have seen many children coming with dengue co-infection or rickettsial co-infection. So depending on your local epidemiology, first and foremost, please rule out all the infections. If a child, especially in this season, dengue, there has been surge of dengue cases. So one need to consider doing a dengue antigen. Remember that antibody can be falsely positive, like dengue IgG or IgM. We may have to rely on dengue NS1 and plus, of course, in addition to the clinical picture. And we have also seen children coming with typhoid or typhoid positive. Again, antibody can be falsely positive. So the rule out rickettsial fever, there can be many co-infection which can exist with COVID-19 infection. So what are the other investigation one need to do if depending on the organ involvement. So many a time the severe infection causes multi-organ involvement. So the children can have, apart from respiratory symptoms, they can have myocarditis like picture, where we may have to do echo or troponin or pro-BNP, or sometimes they do come with AKI like picture. So renal function test might be mandatory to do. And very important is complete blood count with neutrophilic lymphocyte ratio, platelet count, and PTA-PTT in test. So what are the inflammatory markers one need to remember and one need to ask for? So inflammatory markers are something like CRP, ferritin, D-dimer, LDH, IL-6, and Procal. So out of which pretty commonly we are doing CRP, ferritin, D-dimer, and Procal. When we need to consider, in case of mild and moderate, generally mild disease does not require any investigation. Moderate late phases, generally when they present in after 1 week of illness, when this post-inflammatory response happens, definitely all children with severe cases, one need to consider to do inflammatory markers like CRP, ferritin, D-dimer, and procalcitonin. So this is the lab parameter, COVID severity, the infection in the mild, what the neutrophilic lymphocyte ratio is main preserved. Normally it should be less than 3.2. It is neutrophil versus lymphocyte. In moderate to severe, it is prolonged. In severe, it is more than 5.2. CRP, depending on your lab cutoff value, in our center, the value of 2, depending on the units also it is expressed. Value of 2 is what we say it's cutoff. Some labs has considered value of 20 as well. So depending on that, generally in moderate, it is raised by 2 to 3 times, and severe, it is raised by 5 to 10 times. Likewise, we can see D-dimer and ferritin. These are the inflammatory markers, especially in severe infection, which is will be very much deranged. And liver function test, if it is the severe disease, one need to consider doing AST-ALT, prothrombin, PTA-PTT, where we can expect derangement in the severe disease. So when what about imaging, role of imaging, chest X-ray or CT scan or ultrasound? So chest X-ray is a useful modality, should be done in all children with severe illness, definitely not indicated in children with mild disease, maybe moderate to severe illness. Yes, no, one need to consider to do chest X-ray. And not many studies have described chest X-ray finding in detail in children. Mainly what we see is peripheral involvement involving the lower zones, peripheral zones, and most often it is bilateral. In adults, there have been many studies which describe chest X-ray findings. Something like, to begin with early phase of disease, they can have ground glass opacities, and to going on to interstitial thickening, and later on they can mimic like bacterial pneumonia, like parenchymal consolidation. So CT scan, is it required? The answer is no. Even including the Ministry of Healthcare has also recommended that CTs should not be routinely done for the diagnosis and management of COVID pneumonia. Maybe we can consider only if there is no improvement in the clinical status, or if children with comorbid condition, something like if a child has come with chronic lung disease, or if a child has come with leukemia, yes, one need to consider CT scan. So the CT scan picture, again showing this ground glass opacities or interstitial thickening or parenchymal consolidation. So there is something I would like to bring to your notice, something called CORAD score. In COVID-19, CORAD 1, in many of the time they come with CORAD, the radiologists will report CORAD score of 2, 3. So we need to know what is this CORAD score. CORAD 1 is normal CT. Suppose you happen to do a CT scan, so you need to look at this score. So if it is a CORAD score of 1, it is a normal CT. CORAD score of 2 is just a tree bud appearance. Generally, this is not a picture of COVID-19 at all. Could be any bronchopneumonia, something like tree bud, cavitation, and thickened or minimal alveolar involvement. CORAD 3 is bronchopneumonia or lobar pneumonia, may be a suspicion of COVID-19, can be raised here. CORAD 4 and CORAD 5 is typical features of COVID-19 infection. So these patients will have unilateral centrilobular non-peripheral ground glass opacities with multifocal consolidation, Choroid 4 is complete ground glass opacities. So based on this choroid score, 1 and 2, there is a very, very low index of suspicion, whereas choroid score 4 and 5 is a very, very high index of suspicion. We need to take in background of, suppose if RT-PCR is negative, but a patient comes with choroid score of 4 or 5, is high likely that this patient is COVID infection. But and again, as I said earlier, this CT scan has not been well described in children. There's other score, something called CT severity score. It's a measure of severity of lung involvement. Again, the score is based on the lobar involvement, right side and left side. Again, 3 lobes on the right side and 2 lobes on the left side. Depending on the score of 1 is less than 5%. Score of 2 is 20%. So similarly, it goes on. So if you have to take a cumulative score of right and left together, if it is the score is less than 8, it is mild. 8 to 15 is moderate. More than 15 is severe. Again, we need to look at this very carefully. And all this is mentioned in adults. And of course, with this COVID pandemic, we have been managing adult as well. We have seen patient with choroid score of moderate 14 to 15, but still the patient is not symptomatic. At the same time, we have seen a choroid score, mild score of 8, and the patient is quite hypoxemic. So each patient behaves differently. So the next aspect which I'll be talking about is respiratory support. So how do we treat or how do we manage these children with severe COVID infection? So remember, all these children should be admitted, preferably in a HTU setup, high dependency unit, or intensive care setup with a dedicated COVID facilities. And that setup should have a capability for managing or well versed with managing non-invasive and invasive ventilation. So respiratory support. What are the various respiratory supports one can think for a child with COVID infection? So to begin with, so any simple nasal flow. So start off with the low flow oxygen like simple nasal prongs or face mask oxygen. Then we need to escalate. Suppose a child is not maintaining saturation, we need to escalate to heated humidified high flow nasal cannula with a 2 liters per kg per minute. If the child doesn't improve with HFNC, then consider using NIV with adequate seal interface, either using a CPAP mode or a BiPAP method. And all throughout, and remember this HFNC and NIV causes aerosol. You need to take adequate aerosol precaution. And these children should be in COVID ward, and all of us should be in PPE. And it's very important that these children has got continuous respiratory monitoring, like monitoring of respiratory rate, work of breathing. If there is a facility to blood gas, so please do monitor PF ratio. If not, SF ratio can also be monitored. So respiratory support, HFNC has gained popularity because during the COVID-19 and many centers have got many HFNC and they have been well versed with COVID-19 during pandemic. So how much flow we need to set in? In a child less than 10 kilos, start with 2 liters per kg per minute. More than 10 kilos, 2 liters per kg per minute for the first time. Then maybe you can add on to 0.5 liters per kg per minute above 10 kilos. So we can set a flow up to 60 liters. FiO2, initially you can start with 60% and reduce. Probably you can come down to 40% if the saturation target is achieved. And during HFNC, you need to monitor the respiratory rate, all the vitals, and work of breathing. And how do we know that these children are responding is by reduction in the heart rate, improvement in their sensorium, clinical improvement, and improvement in their respiratory rate by 20%. Then this is HFNC success. So if the child is doing well with HFNC, probably for a day or two, you can leave on HFNC and start weaning this patient. Weaning by decreasing the FiO2 from 60 to 40 to 50, 30%, and then start decreasing the flow by 1 liter per minute every 4 to 6 hourly based on the clinical parameters, and change to nasal prongs if stable. So this is how we are going to escalate the respiratory support in children with COVID-19 infection. So this is a summary of this. So to begin with, start with nasal prongs, 1 to 2 liters per minute. So escalate to 4 liters. then change suppose if the child is not maintaining saturation with 4 liters per minute of nasal prongs, change to face mask oxygen to 5 to 6 liters, or if there is if you have bubble CPAP, one can try bubble CPAP and set a target of 3 to 5 centimeter of water, then escalate to HHFNC if the patient is not improving with face mask oxygen, and to start at 2 liters per kg per minute, which I described previously with 60% FiO2. And if you show improvement, leave these children on HFNC. If not, escalate to non-invasive ventilation. So titrate oxygen up and down basically to maintain saturation of 94 to 96%. Vital monitoring is the key. Allow at least 5 minutes at each setting before you adjust for the further settings. And once the patient is stable on minimal oxygen, then consider discontinuation of oxygen treatment. Suppose the patient doesn't improve even on NIV. If the saturation is 92 borderline saturation, if he is requiring high FiO2, more than 60%, there is increased work of breathing like suprasonal retraction, subcostal retraction. So sensorium is dropping and the child is developing shock. One need to abandon NIV and these children should be intubated. So this is a summary of how we escalate or de-escalate respiratory support. So if in case these children land up with mechanical ventilation, please do take adequate precaution. The intubation and ventilation itself can cause a lot of aerosol generation procedure. So one need to do within a closed box intubation and prevent transmission as far as possible. Use HME filter. This is a HME filter between the ET and the ventilatory tubings. Always choose a cuffed endotracheal tube, and as far as possible, minimize the discontinuation should be minimal, and suction should be a closed suction circuit, and avoid nebulization. So we need to take care of adequate precaution to prevent the aerosol generation procedure. So what about how do we treat these children on mechanical ventilation? That depends on whether there is something which is described theoretically by Gattinoni et al., whether these children have got H-type or L-type phenotype, does it matter? So what is this H-type or L-type phenotype? L-type phenotype are one who has got low elastance and high compliance. They've got low lung weight, low recruitability. They are the ones which was minimal involvement, and they can be managed by not intubating, just by non-invasive ventilation like HFNC or CPAP or NIV. Whereas L-type, once they progress, this is a progressive lung disease. When they develop severe disease, where we can see a lot of consolidation, patchy consolidation, bilateral overload. The H-type is high elastance, low compliance, high lung weight, high recruitability. So one need to intubate these patients early, and they should be treated like severe ARDS, like optimal PEEP, lung protective strategies, early proning, and ECMO if required. So what are the principles of mechanical ventilation? So lung protective strategies as good as any other ARDS. So where we use low tidal volume ventilation, 6 ml per kilo, monitor plateau pressures less than 28 to 30 millimeters of mercury, optimal PEEP to open up the lung and to keep it open, avoid hyper oxygenation, just keep FiO2 at 60% and give them good sedation, analgesia and neuromuscular blockade. If they are refractory hypoxemic, these, especially the H-type, they do respond well to recruitment maneuvers. Yes, either high PEEP in gradually increasing or decreasing recruitment maneuver one can consider. You can consider giving neuromuscular blockade. Along with all this, consider proning these patients and transfusing and keeping your hematocrit to 30 or hemoglobin of 10 gram per deciliter. So having learned with respiratory support, what are the other general support or general and supportive care and drug treatment available for COVID-19? Supportive, as we know that COVID-19, there is no specific medication. It is mainly symptomatic treatment apart from steroids and sometimes antivirals. Supportive care is very, very important. So we need to start early enteral nutrition, restrict fluids, maybe 2/3 to 50%, monitor fluid overload in this patient, generally avoid antibiotics unless if there is any clinical suspicion of secondary infection or septic shock. So steroids is the key. Various trials have come with regards to steroid treatment in COVID-19, and one of the landmark trial is recovery trial, where steroids has been very well studied. It may be used in rapidly progressed moderate and severe disease. Remember, one should not be using in mild disease or in the early phase of disease, especially avoid in the first 3 to 5 days of illness. Start after 5 days of illness. Most commonly used steroids is either dexamethasone or methylprednisolone. The dose in children is 0.15 milligram per kg per dose, given once a day, or methylprednisolone equivalent. Duration is for about a week and taper over 14 days. So many studies have shown that steroids prolong viral shedding, and hence you should be very, very cautious. And using, especially in the recovery trial, the early phase, the patient, there has been increase in mortality with the usage of steroids in the early phase of COVID-19 infection. Antimicrobials have got no role in prevention or treatment of viral infection. Is the asymptomatic and mild cases definitely not recommended, but many a times in severe cases and moderate cases, there can be a concern of superadded infection. So one will consider adding on antimicrobial, especially if there is hospitalized or risk of healthcare associated multi-drug resistant. So no, you can start with either amoxiclav or Ceftriaxone, third generation cephalosporin, if and provided you send all the cultures, bacterial culture, blood culture and respiratory culture. Anticoagulants, yes, it is being recommended that anticoagulants should be used because of the pathology itself, where there is a microthrombi, especially in the lungs. So anticoagulant should be considered in children if there is a risk of venous thromboembolism, subcutaneous low molecular weight heparin. If there is any of these risk factors, yes, or in children with severe disease, anticoagulants needs to be given. So the dose is 0.5 mg per kg per dose Q12th hourly. But suppose there is obvious thrombosis, double the dose to 1 mg per kg per dose 12th hourly, given for at least 2 weeks. Role of antivirals. There have been many studies that remdesivir or any other antivirals are not got mortality benefit, but we can consider, even the IAP also recommends remdesivir can be considered if there is a progressive pneumonia or a severe disease, or if it's a high risk patient with a significant chest infiltrate. Best is used early within 12 days. So beyond 2 weeks, it is of no role. And the dose is mentioned. Be careful. This can cause hepatic derangement. So one need to monitor AST and ALT, though it is very, very rare. Hepatic impairment can be caused by remdesivir. So this is the gist of antivirals and immunomodulators in COVID-19 infection. Of course, this is all extrapolated from adult. As we can see, in the mild constitutional symptoms, if the patient present with a mild, it is just a symptomatic treatment. Only if they go to pulmonary or hyperinflammatory state, when they present with all the bad chest X-ray, with clinical severe disease and requiring ventilation, present with shock, one need to consider antivirals. Chloroquine, no. Hydroxychloroquine, no. Convalescent plasma in children, there are no studies and we haven't used. So definitely it is not indicated. Steroids, yes, don't consider steroids in the early phase of the disease, but late phase of disease, definitely it is done wonders, and it is known to decrease the or improve the outcome. So this is how we treat a severe disease. Investigation wise, at admission, we do a complete urinogram, renal function test, liver function test, along with that inflammatory markers. One need to look at the blood gas, look at the oxygenation and carbon dioxide, and X-ray is required. Definitely there is no role for CT, and we may have to repeat it 24 to 48 hours later, and watch out for MISC. And treatment wise, dexamethasone along with low molecular weight heparin at a prophylactic dose can be considered, and escalation of the respiratory support with starting with nasal prongs with HFNC, NIV and invasive ventilation. Suppose these children develop with ARDS, It is like lung protective ventilation, like any other ARDS, you need to treat these children. So I think there was a talk on MIC. I would not go in detail of MIC, but however, just 2 slides on MIC. So I think all of us have seen these, I've been getting these children with MIC who present with fever, irritable, cold extremities, tachycardia, and shock. So the treatment for MIC is nothing but we need to give them steroids and IVIG. Apart from airway breathing circulation management, shock management, one need to restrict fluids. Don't pump in too much of fluid bolus. Just give small aliquot, because many of these children present with cardiogenic shock, and consider giving steroids, early steroids and IVIG for these children. So for a couple of more minutes, I would like to present the WHO study of severe COVID-19 disease in children. It's a multi-country study in low and middle income. One of the center is St. John's Hospital. This is over last 1 year we have collected the data. This is our study flow chart. This include both prospective and retrospective. Retrospective was from this year, Jan 2021. Prospective was from Jan 21, and retrospective was last year data. As we can see here is, this was a study which is conducted across India, Asia, and Africa, few parts of African countries. So this is our Indian data. Last year, this is only children with severe infection. As we can see, severe to moderate pneumonia, out of 525, about 69 were severe to moderate pneumonia. Most of them were mild cases, mild COVID disease, about 30%, only 13%. And MIC cases were last year around 13.9%. This time also it is more or less, it matches the same. So where MIC, but the MIC cases have increased. The mild cases is not much. Even the severe cases also, there is no difference. This is the surge of cases, severe cases from last year to this year. As we can see, there was a spike last April, May, June. And this year again, we can see that spike happening here with severe cases. And this is the MISC cases. As we know that MIC is post-COVID generally, even with COVID positive also we've seen MIC. With post-COVID, after that the first wave surge, we started seeing this surge somewhere around August, September and October, November. And this year, along with the COVID infection, we saw the surge of MIC cases as well during the month of April, May and June. This is the age category. We saw equal distribution, but predominantly it was common in 5 to 12 years, around 30%. It was less common in children with less than 1 month. 1 month to 1 year, 21%. 1 to 5 years is 26%. More common in children with 5 to 12 years, around 30% of the cases, and 33% of them were females. This is the organ system involvement among confirmed MIC. So the MIC cases, they predominantly affected cardiovascular. Many of them came with cardiogenic shock, coagulopathy, and gastrointestinal symptoms was pretty common in MIC cases. For the clinical characteristics at presentation of these children with hospitalization, severe infection, 70% of them had fever. Cough was not much, around some 25 to 30%. And as I said, diarrhea and vomiting. The children presented with GI symptoms were much higher than respiratory symptoms in children. And about this year, there were 11% of them presented with respiratory distress and shock. Many children, around 48 to 50% of them present with shock with MIC. Unconscious is around some 6.7%. And rest of the presentation. And to summarize, children with severe disease were 61 out of 373. We had 61% of COVID-19 MIC was this. I'm talking about this year, which very well matches the last year. There is been no increased change in the disease pattern when it comes to COVID-19 positive children, whereas MISC, there have been a huge increase in MISC. It's almost doubled. Last year it was around 12.4%, and this year it is 23%. And mortality, as we can see, in children with severe disease, non-MISC, around 19.9%. The mortality is very high because predominantly a lot of these children had comorbid condition, unlike last year where the mortality was less than 10%. Children with severe disease, MISC cases, mortality, many of them presented early, though, and the mortality was much lesser compared to last year. And when we compare between the last year data with this year data, we can see there is a huge increase in the MIC cases, and the children mortality was increased with severe disease, non-MIC cases. And 22% of these children had comorbid conditions like rheumatological disorders. Many of them had leukemias, CKD, CLD, and other comorbid conditions. So I'll come to that end of the presentation to summarize. In children with COVID-19, severe infection is very, very less, around 1 to 5%. So they can present with severe pneumonia, or they can come with presentation like septic shock, ARDS like picture, or myocarditis like picture. One need to be very, very vigilant, recognize them early and treat them early. And oxygen therapy has to be escalated accordingly. And steroid is the key. It should not be used in the early phase of the disease. Suppose these children do get intubated, managed like any other ARDS, consider awake proning, which I didn't cover much because of lack of time. And other management, intensive care management remains the same, like use choose antibiotic wisely, restrict fluids. And this is IAP COVID-19 guidelines, which been this is the standard protocol, and all of us do follow the protocol of this IAP, where everything has been clearly specified and mentioned, that how to treat mild, moderate, and severe infection, and when to investigate these patients. This is one slide about respiratory support, how to escalate, like early oxygen therapy followed by HFNC or NIV, and then go on to invasive mechanical ventilation. And definitely in the early phase of disease, please do not intubate these children, because these children have got low elastance, and compliance is very, very good. We will be doing more harm by ventilating these children at the early phase. It should be ventilated at appropriate time, and use ARDS strategies like low tidal volume ventilation and high PEEP strategies. And of course, ECMO and INO, not many studies are not tried, at least in our center or any elsewhere as well. So with this, I would like to come to the end of this presentation. Once again, I would like to thank IMA branch for this opportunity, for giving me this opportunity to share our work on COVID-19 disease. I hope it has been useful. Thank you so much.
Madam, thank you very much. It was, yeah, Dr. Karudakar is there?
Yes, sir, I'm there.
Yeah, right. It was very nice moderation.
Thank you, sir. Thank you so much. Dr. Lalitha, it's a wonderful presentation. Of course, it's important for us to discuss various issues related to how we are all supposed to take the message from you for managing this patient in the community. That's what is our concern, actually. You covered very lucidly about various aspects of management of this patient who require hospitalization, intensive care unit, and all other requirements. Thank you so much. Few things I would like to bring it to your notice. I'm also requesting our members to put it in the chat box. It's an opportunity for all of you to discuss the issues related to COVID-19 with the expert who is basically an intensivist. So if I remember, St. John's is one of the places where pediatric COVID patients with critical care service has been provided in the second wave at least. So basically, it's going to be a wonderful first-hand experience for each one of us from Dr. Lalitha, actually. Dr. Lalitha, a few questions to you ask, actually, like, I possibly believe, as you pointed out, pediatric COVID is not like an adult COVID. Yes, we agree and totally that we have been reasonably lucky as a pediatricians that we have not, unfortunately or unfortunately, we have not been in thick of action with respect to COVID patient care. And we've also been lucky that we did not see much mortality as per as COVID because there's very few admissions, right? But you remember in the second wave, especially from Maharashtra, Delhi, and those places, a lot of reports have emerged suggesting that they had seen large number of moderate to severe cases. Actually, that's where literature started emerging with respect to pediatric from the country, right? So we'd like to ask with respect to the investigations, like whatever the battery of tests has been publicized, various protocols by WHO, Government of India, everybody. Practically, it's on a kind of a consensus guidelines developed by experts across the world for ensuring that we find out things and do it, right?
Absolutely.
But now my question is that in pediatric patient, do we really need all these states actually? That's first thing actually, because let me tell you, like we manage a large number of patients with pediatric viral infection in the ICUs. We know that COVID-19 for all practical purpose, for us, it's like any other viral infection, right? Except that it's a pandemic. There is certain concern about infectivity and mortality. For us, it's practically, there's nothing actually. So in that background, there are two questions to you. Is it that whatever the inflammatory response we are seeing in this patient is specific to COVID, or is it you see them in other viral infections also? Second point is that why do we need cardiac markers in this patient in pediatric patients? Like in adults, of course, we need it, but why do we need cardiac markers in pediatrics? Please.
Yeah. As I said in my presentation, sir, thank you very much for the question. As I said in my presentation, mild disease, definitely there is no role for any investigation. The small percentage of them, and as what we have seen is many of the times it's a bystander. COVID-19 is a bystander rather than causing disease. So definitely just a simple blood count should be enough. And what we need to look out for lymphopenia and neutrophil lymphocyte ratio. But if they're present with severe illness, like severe pneumonia, yes, one need to consider doing chest X-ray, basic chest X-ray, CBC, and those investigation of inflammatory markers will tell whether this is a going on to hyperinflammatory phase, whether we need to consider apart from steroids something like IVIG or not. Not that all children with severe infection as well, if they come with, as you very rightly said, sir, many of these patients are come with more of with MIC like presentation or with mild to moderate pneumonia. We had 4 children whom we have intubated. They were all having underlying leukemia, CKD, and the last case which I described, she was absolutely normal child who we did steroids, we did IVIG, we pulsed her. From COVID-19 infection severe, she went on to MIC. So very, very small percentage of case do land up with MIC. For that, definitely these investigations are required. Other viral infections, we have not seen mortality like this, or there have been no studies which is about the investigation or inflammatory response. This is a little bit unusual, and we all understand about the immunopathogenesis of COVID-19, how that inflammatory outburst happens. All this we have to extrapolate from adults. I think you can also share your experience about COVID-19. Even at Ramaya as well, I guess they do take care of all severe infections. Sir, unmuted.
Kindly unmute, sir.
The first wave, basically, we stayed away from the COVID-19. Second wave, we started admitting the patient. It's more of a stable patient. So as far as critical care, till now, we don't have any experience to share actually. But for the third wave, we are getting ready with every kind of training and expertise to see that we provide that care in the third wave in the Ramaya Hospital. Thank you so much. I ask one more question. Like now, it's been a kind of craze as far as the usage of antiviral goes, right?
Yes.
Everyone of us can remember that the way the cost of remdesivir went up, it's basically skyrocketed everywhere. Yeah. And we also, as you rightly pointed out, many medications have been desperately or empirically tried in these patients, right? Now I want you to really convey the message that is it really there is any scope for using antivirals in children actually, like including remdesivir?
Yeah. So again, it should be reserved for only progressive disease and definitely not for mild, moderate, even for severe disease. Against remdesivir, even in adults, has not shown mortality benefit at all. So suppose this is, but if at all, if you are using, use it little early around for a severe disease, progressive disease with lot of comorbid condition. Like we had a child with adenocortical carcinoma, came with COVID-19 positive, got intubated. So out of 60 children which we presented with severe disease, we have used it only for 4 children. So you can see the proportion of cases. Yes, definitely, as rightly said, I don't believe in using remdesivir for all children, and there is no studies which has shown any mortality benefit.
I remember basically like with respect to remdesivir guidelines, they say use it for children more than 13 years, right?
Yes,
There's
sir.
also been certain guidelines with respect to usage in the neonates also actually.
Yes.
But the question is that how does it make sense for not recommending for rest of the population actually in that case, right?
Yeah. They say it is very safe. In children at less than 12 years, no studies has happened, but it is quite safe. But they mentioned that it can cause hepatic derangement. We have used it in all those 4 children, out of which 1 child died. 3 children, of course, they came on whether because of remdesivir or steroids or innate immunity, I'm not sure. But only out of 60 severe children, only 4 cases we used with treated with remdesivir.
Okay, thank you, Dr. Nanita. I have 1 or 2 more questions before we move on further. See, again, like asked about cardiac markers, it's
Yes.
basically required in the adults because of certain health risk related to the adult population and aging population, right?
Yeah.
Similarly, what is really the need for using these anticoagulants in pediatrics? That's another concern I've got. I would
Yeah.
like to argue.
So the pathogenesis of COVID-19, if you see, it's all microthrombi. That's why I would took you to that pathogenesis slide. I presented the pathogenesis slide. There is a diffuse alveolar damage mainly because of microthrombi, and anticoagulant has got a role in COVID-19 infection. When they come with chest infiltrates, it's all because of the microthrombi and diffuse alveolar damage. And anticoagulants should be considered if there is severe disease, and if platelet count is good and the child does not have coagulopathy, and if the child has got severe myocardial dysfunction. So if these are the conditions, there are certain conditions. Otherwise, not prophylactic anticoagulant is not recommended in COVID-19 disease.
Yeah, thank you. One more question, like you also remember that it's a craze that pulse oximeter, right? Pulse oximeter monitoring is craze among adults. Now, concern with pediatrics is that, again, if you have a data to tell us basically, has it been found to be useful as far as monitoring mild cases or asymptomatic cases at home? Second, we also have concern about using this pulse oximeter in a pediatric population because size doesn't matter actually. Doesn't match us actually.
It is size doesn't match, ambient temperature, child will not it keeps on moving, lot of artifacts. I don't know about the studies. Let me get back to you with the studies of role of pulse oximeter. But now it's become a household commodity. Every patient, whether COVID or non-COVID, they come with a pulse oximetry reading. But maybe I think we should ask again, if at all, if you're discharging a mild case or asymptomatic, ask them to use appropriate size pulse oximeter and maybe a frequent monitoring. Not depend on pulse oximetry reading. The red flag signs one need to watch out for, like high grade fever, persistent vomiting, poor feeding, along with this pulse oximetry reading, sir.
Okay, thank you so much. And
Thank you so much.
we already covered, actually don't want to take it further. But one more thing I want to say now, again, with pulse oximetry, the second wave we exposed the deficiency or lack of oxygen availability. Do you think it could be an issue for pediatrics too?
Not sure, sir. The issue of pulse oximeter? I'm not sure. Oxygen therapy. Okay, so even in this WHO study, there are 3 countries which is involved. We can see that severe cases are very, very less. We still feel that the third wave will be predominantly adult only. I hope the children will not come with the severe disease. But yes, there are certain subset of population do land up with the severe disease. One need to be vigilant. So I just hope it will not be as bad as what it is in adult, and that way we are lucky and fortunate enough that kids are not much involved. But MISC, yes, MISC, there have been a surge of MISC cases. Yes,
yeah, definitely we are seeing more of MISC now. See, as I could recollect from your presentation that at this point of time with available literature, pediatric severe COVID is less common. And then of course, most of the patient can be managed with like a regular patient with some amount of medications. Of course, steroid is an important component of therapy, less role for remdesivir. And you also mentioned about IVIG. Really, you think there is a role for IVIG in this patient?
Only in MISC, sir. Only in MISC.
Yeah, MISC
Yes,
is a different
MISC cardiac involvement, not in a severe, just pure severe COVID-19 infection in children.
And Dr. Lalita, I want to bring out one point here, like for example, say what we understand with MISC till now, what is available is basically like it's expected, it's been happening in children suspected to have exposed or had an infection
Yes.
with COVID
Yes.
2 to 4 or 6 weeks after the illness, right?
Yes. Yes. Yes.
So do we really need to worry about MISC in critically ill COVID patients?
This year particularly, we saw COVID positive patient coming with MISC. So if you look at the WHO definition, children with fever of any child with fever of more than 3 days, either RT-PCR positive or antibody positive. So especially in this April-May month, whatever MIC cases we saw, about 60% of them were COVID positive. And currently what we are seeing are all antibody positive. So 2 to 6 weeks, yes, definitely one need to watch out for these MIC cases. Probably the comparison of different modalities of treatment, the AIIMS has launched a study with all the hospitals across India where they are comparing the treatment modalities of MIC, whether IVIG or IVIG with steroids or steroids alone. So I think that paper should be very soon published, and so we'll get a first-hand information from developing country like us to follow regarding that IVIG treatment, sir.
Okay.
So shall we go for second speaker? He must be waiting.
Thank you, Dr. Lalita. Thank you so much.
Thank you very much, sir.
For further discussion in the end of the session, we'll be more than happy to have you up too.
Thank you. Thank you.
It's over to the second speaker.
Yeah, may I request Dr. Geeta Doppa Madam to introduce our second speaker, Dr. Mahesh sir, who is going to speak on guidelines and practical tips to the clinicians on asthma management during COVID-19 pandemic.
Good evening, everyone. So our next speaker for today is Dr. Mahesh PA. He is a professor of pulmonary medicine in JSS Medical College and JSS Academy of Higher Education and Research. He is going to talk on guidelines and practical tips to the clinicians on asthma management during COVID-19 management. So Dr. Mahesh has many publications to his credit. He has around 180 original articles. In that, 152 international publications, 28 national publications. He has authored 3 books, authored chapters in 8 books. His H index is 53, I-10 index is 98, and around 46,886 total citations. So average impact factor is 16.2. The areas of special interest of Dr. Mahesh are asthma, COPD, air pollution, and food allergy. So we all know that the patients of asthma are at higher risk of lower respiratory tract infection as compared to the general population. So definitely COVID-19 virus infection can be particularly troublesome for those with asthma and also their clinicians. So let's know from Dr. Mahesh the guidelines and practical tips to the clinicians on asthma management during COVID-19 management. Over to you, Dr. Mahesh, sir.
Yeah, thank you, Dr. Geeta, for your kind introduction. Can you see my slides?
Yes, sir.
Okay, thank you. All right, so let's look at what is the impact on this COVID-19 pandemic. And the most important impact for a chest physician especially is the inability to perform spirometry, because that's the gold standard for the diagnosis of asthma and the gold standard for the following up of the patient with asthma. How well is the patient doing? So a lot of the patients, due to the possibility, we are doing much less spirometry than earlier. So we look at a little bit about asthma management. The guidelines for asthma management generally remain the same. but we will look at what are the impact of this COVID on the asthma management. Now, asthma is a very common chronic non-communicable disease. About 60 million people globally in 2019. Now, its classical symptoms and character is that it is a variable. The symptoms are variable. You have wheeze, you have shortness of breath, you have chest tightness and cough, and each patient may have one of these as his dominant presentation. Not only the symptoms are variable, lung functions are also variable. These are the two hallmarks of asthma that we have to demonstrate to diagnose. Especially people will have a problem when patient comes above the age of 40, when you can have COPD and various other airway diseases also present. Now, this is usually associated with airway inflammation. There is a lot of information on non-eosinophilic airway inflammation as well. And the most important one being a neutrophilic inflammation. And what everyone should know, every doctor who is seeing asthma should ask their patient, whether it's a child or an adult. There are factors inside the house that can an inflammation, which is easily treatable, steroid responsive, to a neutrophilic inflammation, which does not respond to steroids. And these are commonly used in most of the homes in India. So what are these? One is the use of incense sticks or agarbattis. Now, Sandeep Salvi from Pune on diesel exhaust in UK before he came to India, and he has done a lot of studies on indoor air pollution. So if you use one incense stick, it is equivalent to burning 5 to 15 cigarettes. The same amount of particulate matter, volatile organic compounds, formaldehyde, whatever is there in the cigarette smoke, you will also get when you burn an incense stick. Change neutrophilic inflammation to a neutrophilic inflammation. Fortunately, it is reversible. So you must ask all of your patients, they can burn as much of as diyas or lamps as they want, but not incense sticks. Now, a lot of families also use doop sticks, that is equivalent to burning 1,000 cigarettes. A lot of families also have about use of mosquito nets, and they use these liquidators. Fashionable, they run it 24 hours a day. If you burn it for 6 hours, it is equal to burning 100 cigarettes. For a long time, we wondered, we saw women, non-smokers, 25 to 30 years with lung cancers. We wondered what was the reason. Now, of course, not every smoker will develop lung cancer, but if someone is predisposed at your bedside for 10 years, that's 100 cigarettes a day. If you burn it only for 6 hours, oh, that's a nightmare. Now, for asthma also, it is bad because it will cause neutrophilic inflammation. These three things, every patient you see who has asthma, you must tell them that this should be abandoned. That's very critical before a simple way that you can contribute to improved asthma care across the board. Now, people with asthma also have worsening symptoms, worsening airway obstruction called as exacerbation. Sometimes that can be fatal. 2019, there was a big major change in guidelines. We will discuss about that. It's important to know that most of the morbidity and mortality associated, particularly with the use of guideline-based inhaled steroids. Now, even after 100 years of discussing about asthma and having world congresses only on asthma, we still do not have a single definition that can encompass all the phenotypes of asthma. But generally, this is the one. It's fairly simple. It is based on the symptoms that we have just discussed in the previous slide. Now, how common is asthma? Now, this is a paper in Lancet Global Health that was published in 2018 as part of the Global Burden of Disease study. State level coordinators, national coordinators, all the states, data was published. ICM are also in this paper. And you find that over a period of 26 years, in most of the states, there is a significant increase in the prevalence of asthma. Now, asthma is a genetic disease. In 26 years, we don't expect the genes of the people small a time period. So what is responsible for this increase in the prevalence of asthma? It is the switching on of the genes. It is the environment that is creating this difference. The genes have to be switched on. If you have 3 people in the same family, the child will come first, and then the father, and then the grandfather. This, all of them have the genes, but the environment, the physical activity, the diet that you're using, the sleep, the stress. So a lot of factors are known to switch on these genes, epigenetics, and the air pollution that we have, indoor, outdoor. So this is the environment that is contributing the switching on of the genes earlier. And that's the reason for increase in prevalence of asthma. Knowing about 2,000 children every 5 years in Mysore. And we also did the global burden, global asthma network study, in which we screened about 18,000 people. And as you can see, there is a significant increase in asthma prevalence. This is important, as we already discussed. The environmental control is critical to reduce the same thing with the rhinitis as well. But it is not directly related to air pollution alone. In 2003, there was a big regulation that brought down the air pollution significantly in all parts of the country. But even with the reduction in the various pollutants, you don't find the asthma prevalence reducing. So it's not the main reason. It is one of the environmental factors that is contributing to earlier switching on of these asthma genes. So how do we go about managing asthma, especially in this time of this pandemic? So I follow a 7-step approach, 2 steps in the diagnosis of asthma and 5 in the management of asthma. The key factor that has is the spirometry. We will look at the alternative that is available. The second thing that is done is the use of the allergy testing. It is critical because you need to find out what is triggering his asthma and how do we avoid. Unless they avoid, they continue getting exposed to the allergen, obviously it becomes difficult to control their asthma. So finding out the key allergen and avoid reduces the medicine requirement. We have seen that 30% of patients, and the patients I see are from the moderate to severe variety, after 6 months, 4 to 6 months of treatment, can maintain without medicines only by following allergy avoidance strictly. So it's very, very important tool. Then we go into the management. The first, if you see, I have can give the best medicines in the world. The patient doesn't understand it, they don't use it, or they don't use it appropriately, then it's not going to be effective. We spend about 45 minutes with every new patient, adult or child. So it's very, very critical. There are whole, it's a 1-hour talk itself to explain what are the key points to educate the parents or the adult. The pharmacotherapy, as I said, allergy avoidance. For a subgroup, about 20% of patients, you will find when the disease is progressive, they need immunotherapy. This is the only known modality that is more than 110 years old now, that can alter the natural history of the disease and can give a chance of cure. How does it give a chance of cure? Different levels of the immune system, it is capable of switching off the genes that are switched on. That's how it works. And of course, if you train them to self-monitor, just like a diabetes will use a glucometer, if you train them, then they can manage themselves without much help. Now, how do we use a spirometer? Why is it? First, it tells us whether a patient has asthma. If you see the differential diagnosis of asthma, you will have more than 25 different causes that can mimic asthma. So it is important that we use a spirometer and diagnose asthma. That's critical. Now, it also tells us what is the severity of asthma. The guidelines are based on how severe the COVID. The GINA guidelines has also changed. How do we assess the dosage? I will discuss that. But previously, we used the spirometer to decide what dose of medicines were required. It will give you an idea. There is airway narrowing, and airway narrowing happens due to two parts. One is what we call as bronchospasm, and the other thing we have what we call as a mucosal edema. Now, how do we determine which one is which? So patient, instead of having FEV1 of 100% predicted, has an FEV1 of 40%. Now you give a bronchodilator. This is only a muscle relaxant. 40% becomes 90%. This is a predominantly bronchospasm. Inflammation is minimal. Suppose after giving bronchodilator, 40% comes to 45% or just 50%. Now this is a patient who has predominantly mucosal edema. After using inhaled steroids, after a month or so, then his lung functions may move from 40% to 90%. So that is how you determine which one is more dominant. Depending on the inflammation, you can decide on the dose of steroids that are needed. Now, does the patient have airway remodeling? Again, that's a very, very important aspect. The lung functions does not reach normal in spite of best guideline-based medications, even after 6 months. You know, this patient already has airway remodeling. There is fibrosis in the basement membrane as well as all. And if you don't aggressively treat this patient, it is going to get worse. The fibrosis is going to get worse, and it's critical for us to identify these patients and be more aggressive in their management. What is the treatment responsiveness? As I said, there is a severe disease, very responsive. We have seen patients, lung function is only 75 instead of 80. But whatever you give to these patients, so they have mild disease, but they're poorly treatment responsive. That's again critical for us to understand, and therefore you need a spirometer. What is their lung function decline if you're seeing the same patient? How progressive is their asthma? So these are some of the information that you will be able to get. So this is your typical normal. This is your asthma, spirometry tracing, and more 12% and 200 ml after using a bronchodilator. So this is the flow volume curve, and this is the time. At least 6 seconds the patient must blow. The patient does blow for seconds, then that's not a good spirometry and has to be abandoned. Now the question, when time of the COVID, what do? We are, during COVID, we are not able to do the spirometry. Then what should we do? What are the other options that we have? The simple one is what we call as a peak flow meter. It's very economical, about 350 to 400 rupees. Patient can keep at home and they can monitor. A single peak flow reading is almost useless. What is to have serial readings. You can have it at least twice a day, preferably in the beginning 3 to 4 times a day. And that's going to be very, very useful. We will see some case studies where this has been very useful. It's a very simple instrument, easy to use. Just take a deep breath and blow as hard, as fast as possible into the mouthpiece. And it, of course, cannot replace spirometry. It doesn't give us all the information. And serial values, of course, are single value. Now here the patient who is not on any medication but has symptoms suggestive of asthma and spirometry was not available. So all these are actual cases that we saw over time. So we gave him peak flow monitoring for a week. And how do we monitor? How do you calculate? There's something called as diurnal variation. Suppose the patient blows and 300 as his minimum. So it is 400 minus 300, that is 100, divided by 400. That is about 25%. So if the diurnal variation crosses 20%, that shows you variable airflow limitation, and that is almost confirmatory of asthma. So this is the chart that we got back. You can see large variation, 300 to almost 100. So it's a huge variation you see. Not every day has the same degree of variation, but this is the variation that you see. This is a typical peak flow meter reading of an asthmatic. Now, how do we decide? When do we reduce the medication? A common question asked by a lot of clinicians. When should I start reducing the dose of? You start treating them with inhaled steroids. You can ask them to do peak flow before and after the medicines. And then you can look at least twice a day. And then slowly you will find that the diurnal variation starts reducing. In the end, there will not be any variation before and after medicines. The time taken for this can vary from patient to patient, but that's the time when you will start reducing. So you see, initially before the amount of difference, but as you go on over a period of few weeks, you will find that hardly any difference. This is the time where you can start reducing the dose of inhaled steroids. Now, how to even manage difficult asthma? Again, this is kind of information that even a spirometer will not give. Now, this patient I saw as a steroid-dependent asthmatic, even when taking prednisolone twice per day, had breakthroughs, whether this is asthma at all, severe breathlessness, and spirometry confirmed the diagnosis of asthma. But when she went to Kerala, she is absolutely symptom-free. Only in Mysore, she is symptomatic. Even with very high dose fluticasone and all the LABA and SABA, she had a lot of problems. So we asked her to do a peak flow meter monitoring. And then we saw that every day at 5 p.m. she was having, it's not the morning, which you commonly see in an asthmatic. Their worst is in the early morning. Then we find out that she was working in the lab and pipetting out these enzymes. She was working on fungi. And when she was not on holidays, this evening dip was absent. And therefore, very, very critical. As soon as we got her to avoid the pipetting, have a lab tech help her out during this pipetting, immediately this is what you see over the holiday period, there is no dip. Otherwise, every day, 5 p.m., there is a dip. But 2-day holiday, there is no dip. So it's very, very important. You will find out the actual trigger, what has happened a few hours before and after that. It will help you to identify. And once that pipetting was avoided, even with 250 microgram of fluticasone, she was doing very well. Some milligram of Physidone per day. So you can understand when it is used. Of course, these are not all described in the guidelines or in the textbooks, but over 25 years of our practice, we have realized when we had difficult cases, what do we do? How do we use this? This simple instrument, but it can give you a whole lot of information. This was Dr. Yen. He was my ophthalmologist. He was a case of sarcoidosis in remission, and suddenly he had an acute onset of cough in the night, and his sleep was disturbed, and he was wondering whether there was a recurrence of his sarcoidosis, but his lung signs were normal, spirometry was normal. We asked him to do a peak flow, and there is no significant variation even in the time when he got up in the night. So that showed that it is not a respiratory disease. It is most likely gastric acid reflux, GRD, that is causing, and he did very well with proton pump inhibitors. So once they have a normal peak flow, in the presence of symptoms, his peak flow is very good. And in spite of his symptoms, even when he got up he is still very normal. And this will give you a clue. Probably is not, or chest tightness is not due to his respiratory problem and due to other system involvement. The PFR dynamic variation is less than 20%. And we should monitor it, of course, when the patient is stable. During the acute episode, the peak flow will drop both in asthma and COPD. It will not help you differentiate. Only in the stable period, it will help you. During an acute attack, even COPD also will drop. Now, of course, why should we do an allergy testing? Now, this is something that we did not stop even during the COVID. Both the patient as well as the technician wearing a mask, we can go ahead and do it. What does it tell us? Is the patient atopic or non-atopic? Why we should know that? Non-atopic or less steroid. Allergen is the patient sensitized to. Dust is not, everybody will say dust. Dust has so many different particles. There are 2 lakh particles in the air that we breathe. That's not going to help us. Now, but what in the dust? Each one has a source. For example, house dust mite maximum in the bed and then in the living room. Fungi in the bathroom and in the kitchen. So, and the pollens generally outdoor. Different pollens have different seasons. So, first to find out what in the dust. So if you were to take care of the bed, then the allergens in the dust across the house will be reduced. And of course, a good history is necessary after the test. Again, that itself is a 1 hour talk. I'm not going to go into those details. And patient, a lot of the things that they tell you, like foods and all that, is an irritant. It is not to the patient. If you touch, it doesn't hurt. I make a cut with the blade, then even if I touch or blow air, it hurts. The blade is the allergen. The touch, the blowing air or touching with water, all that can cause pain. That is like your triggers. Once there is airway inflammation due to the allergen, you become hypersensitive to many of these foods or even weather. There is no weather allergy, or very rarely, Mysore, you have food allergy. And the possibility of an allergy avoidance and the concept of allergy threshold. It is very important. And if you can avoid the allergen to a certain extent, and if your tolerance level is greater than the environmental allergen load, you don't need any medicines. So patient, his genes are still switching on, he doesn't need medicines because he is able to reduce the environmental allergen load to a degree lower than what he tolerates. They are cured. Actually, they are not, but of course, they feel they are cured because they're not using any medicines. Again, I'm not going to go into the details of the various indications. Of course, asthma is one indication for a skin prick test, and these from the patient that a similar reaction is occurring in the nose and lungs. And that gives a lot of confidence to the patient that the doctor knows what he's talking about. And it's very, very important that we try to get these allergy testing done in as many patients of asthma as possible. Now, these are some of the simple questions that we need. It's very important even in the time of COVID. And the single most aspect of a successful asthma management program anywhere in the world. The language has to be simple, otherwise they will not understand what, why, how, and when it should be done. Why steroids are preferred over bronchodilators. How do we explain that to the patient? Your Asthaline or your salbutamol is like water. Steroids are like your rice or wheat. That you simply use it, but it's not going to satisfy your hunger. So steroids are useful to heal the underlying disease. Why you should take treatment regularly? They have done studies, 4 to 6 weeks, patients are okay, but the allergic cytokine levels in the airway mucosa biopsy done every month in a bronchoscopic biopsy took 4 to 6 months to reach non-asthmatic levels. That's used regularly. What are the limitations of medications? What is the need for avoidance, the need for immunotherapy in selected subjects? All these things need to be educated to the patients. Now, what do we expect when we use guideline-based treatment to manage our asthmatic patients? If you catch them early, then it's an important tool to prevent airway remodeling and other consequences. Symptom relief, better quality of life, good sleep, able to go to work or school, good exercise or paying capacity, normal lung growth in children, normal decline in lung function in adults. About 18 to 20 ml of decline in lung functions is seen in adults after 25 years of age. If asthma is not controlled, this becomes accelerated. So when the patient at that point of time, they will not, say 55, 60 years of age, their lung age is 90 or 100 years. They can only move only so much and they feel very weak, but that time you cannot reverse it. And of course, the patient should not have any side effect from the medicine. These are our basic goals when we are planning our treatment. So this is GINA 2021. What are the basic guidelines? We will go through. Now, they talk of the asthma management. Now, you need to assess, that is, confirm your diagnosis. I have discussed, look at comorbidities, control of rhinitis or sinusitis, look at whether the patient is using the medicine properly. What are their preferences? Also, you need to ask. And you need to adjust your treatment accordingly based on the patient's response. If he has not understood, you will have to educate them and skill them. And again, then review a dose, but after 3 months during winter, that dose may not be sufficient. So look for acute attacks, look for side effects. You may have to modify. There is oral candidiasis, dysphonia. You may have to switch to cyclosamide, for example. Look at lung functions. Are you able to reach 80% at least of lung function predicted? What is the patient satisfaction? So you need to work with each patient. It's not just one guideline fits all. Work on an individual basis to see that the optimum benefit for a patient can be achieved. Now, 2019, of course, we started practicing this 10 years before it came into the guideline. So what is this change that they talk about? Now, in step one, so-called step one or early asthma, they said use only salbutamol or levosalbutamol. That was the recommendation since for almost about 20 years. Now, even for the mildest asthma, patient would need inhaled corticosteroid. So why did they make this change? This is, they said, population level risk reduction strategy. For example, like using a statin for lipid disorders or antihypertensive. There is no immediate benefit, but if you look at 20 years, 30 years, will be reduced. So asthma-related morbidity death will be reduced. So they said now, regardless of whatever is the stage, patient should go on inhaled corticoids. So that's the guideline. And why did they make these changes? And these are not new. This is already published in 2007. 30% or more of adults with acute asthma were classified as mild. Of patients with near fatal, they needed ICU admission, were classified as mild. And 15 to 20% of adults actually dying of asthma were classified as mild in the previous 3 months. Now, this is a critical bit of information that has been languishing and did not reach the guidelines for almost 13 years. But this is critical. We had observed that very early in our clinical practice that when severity according to the guideline does not actually match with some of these patients, how they respond over the next 1 year or 2 years or 5 years. Of course, the triggers are unpredictable, and SABA has been first-line treatment for 50 years, but not anymore because of these reasons. They have changed the guideline. So, and they found when you use it regularly, it is associated with adverse effects like a beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, decreased bronchodilator response, increased allergic response, increased eosinophilic airway inflammation. All these were to be observed when only salbutamol was used. So what is high use? if the patient uses more than a year, it is considered as higher risk, higher use. And if they use more than 12 canisters, there's a very higher risk of death as compared to people who use less than 3 canisters. How can we avoid this? Use of inhaled corticosteroid. That is how it has come into the guideline. So there are now, so this was used here. Now you will see that there is ICS LABA. You can use only ICS whenever a short-acting beta-agonist is used, but this is the preferred. Even for the mildest asthma, inhaled steroid and LABA is preferred. You move into, then you need to use it regularly, and you can go to medium dose or high dose. You can add LAMA, you can add biologic treatment. So this is the important change that happened in 2021. Now, when do we use this? When do we use this? So what are the, now spirometry we don't have during this time of COVID. So what do we do? So if someone has symptoms less than 4 or 5 days in a week, you can use low dose ICS format. If symptoms on most days are waking with asthma once a week, one night they wake up with due to their asthma. Now they have to be on regular inhaled steroid and formoterol. Now they have daily symptoms. They wake up due to asthma more than once a week, or the lung functions, if you're able to do, is low. Then you go on from low dose to medium dose. This symptom control is still partially controlled or uncontrolled. Then you start escalating with various other possibilities. So this symptom-based decision of whether low dose or medium dose or high dose, again, is something that has been coming up for the last couple of years. So this is a simple algorithm. So how common is the symptoms? How many times in a week do you wake up? If it is daily, then straight away go for medium dose. If the symptoms, it's a no, but symptoms on most days or waking at night is only once a week, then you can go for low dose ICS formoterol. Symptoms twice a month, then you can go for when. So this symptom-based modification is the main change that we have seen over the last few years. Now, what about asthma and COVID-19? So I'm a steering committee member of the American College of Chest Physicians for airway diseases. And we wrote this, 4 of us wrote this review of literature and a guide on asthma and COVID-19. Now, asthma exacerbations triggered by viral infections can be associated with adverse outcome, and this is true of any virus. Now, the US CDC initially stated that patients with asthma are at increased risk of complications from COVID-19 related respiratory disease. But now, if you look at the evidence, we said, now that's not true. And from our airway disease network. Now, asthma does not increase risk of acquiring COVID-19 infection. Key, especially if the patient is on regular treatment, then the risk of acquiring COVID-19 infection is even lower than the general population. So it's very, very critical. So especially those who are on regular treatment is lower than people who are non-asthmatic, but they should be on regular treatment. If they're not using inhaled steroids, then the risk is higher. How does it work? Inhaled steroid reduce the number of ACE receptors, which is one of the points of entry into the cell of the virus. Therefore, the door itself for the viral entry to the cell is reduced, the risk of infection is reduced. What should we do about steroids? Steroids may be even protective, even in severe COVID-19. And of course, biologics also appear to be safe for use, but inhaled steroids can be protective. So most of our patients with COVID-19, along with the initial parenteral steroids, when they have severe disease, we tend to use inhaled steroids, especially cyclosinide, because it acts on PAC1. COVID-19 drugs act on three main pathways. One is an RDRP pathway, that is RNA-dependent RNA polymerase. It's important for the viral replication. Second is the proteases. And the third is a protein called PAC1. So cyclosinide, of all the inhaled steroids, is found to be a PAC1 inhibitor. It reduces viral replication. So inhaled steroids are actually protective to prevent severe COVID infections. Now, what about COVID vaccines? Every patient with asthma should receive vaccination. What about inhaled steroids? It does not impact vaccine effectiveness. What about patients on oral steroids? If it is a short course, it doesn't matter. It is a treatment for months, then it is going to make it less effective, like any immunosuppressant, but still they should be vaccinated. You can monitor their antibody response to know how good it was, but still they should be vaccinated. What about biologic therapy? They also should be vaccinated. Does asthma increase the risk of death from COVID? It does not confer an increased risk of death. Patients with COVID-19 were 48% less likely to require ICU admission and 58% less likely to require mechanical ventilation. And they were not at increased risk of death as compared to non-asthmatics. Now, asthma alone, of course, does not increase the risk, but there are comorbidities that can increase. So we did this like a traffic zone. Now elderly, women, smokers, diabetes, hypertension, obesity, and dyslipidemia, all these confer increased risk. It is not due to asthma, but asthmatic with this comorbidity only have an increased risk. So these questions have already been dealt with previously. So what are the implications for asthma management? Of course, we cannot do here. So our monitoring is only symptom based, and therefore we need to be very careful in assessing the symptoms and adjusting the dosage for the asthma management. Are there more acute asthma attacks? Actually, many of them saw a reduction in asthma exacerbation as well as influenza. We also saw that this may be due to wearing a mask or the hand washing or physical distancing that made a big difference to these triggers. What about medications? As we have seen, ICS is protective and they should continue, but use a metered dose or a dry powder inhaler, but do not use the nebulizers where possible, because this will cause an increase in aerosolization of the COVID virus, especially in the hospitals. Patients should go on a metered dose inhaler with the spacer in the very young or the old who are unable to coordinate, but nebulizers are preferably avoided. Infection control is key. We do less of spirometry unless now we are during this period, we're not seeing much of COVID, but the third wave will start, we may have to stop again. And monitor strict infection control procedures, even during not only nebulization, induction, even during ventilation in the ICU, non-invasive ventilation, intubation, we should be very, very careful. Now, what are the deficiencies of the GINA guidelines? Now, for the next 15 minutes or so, I'm going to be very quick. Most of the data that I will be presenting are from our own studies. Just a few of them I have shared here. So what are the deficiencies of the GINA guidelines? One, GINA does not talk of progression of disease. You talk to a patient who has been suffering for asthma for 5 to 10 years. How was it in the first year? How is it now? Invariably, you will find that it is worse. GINA doesn't talk about it. Maybe in the future it may come. They don't talk of treatment responsiveness. I have discussed what it is earlier. They do not provide guidance on asthma prevention. We need to, one child is having an asthma, we ask for a second child. What is the risk? How do I prevent? What should I do? Again, it doesn't do that, but it's critical and key for the clinicians to know about it, because that's what the mother or the other people will ask you. They do not provide guidance on management or specific phenotypes of asthma. So what is this disease progression? Now talk of disease progression, so I have come up with my own definition. What is progressive disease? Compared to earlier, there is an increase in frequency of symptoms or acute attacks, increase in annual medicine requirement, reduced response to medications. Within half an hour of nebulizer, child would be all right. Now, even after 2 days, child is not. In severity of symptoms, increased time taken for the attacks to respond. Rhinitis progresses to asthma, or the asthmatic develops rhinitis. So these are some of the points by which you can say disease is progressive. So how common is progressive disease? We looked at, of course, 4 categories. This is something we published in 2009, and percent of the patients have progressive disease. None of the present guidelines offer any solution to halt the progression. Immunotherapy is one that can halt the progression of the disease. We need to look at, are there any other modalities? What is treatment responsiveness? I have given you an example. 40 become 90 within a few hours after giving a bronchodilator, or it may take weeks or months. So this is what we call as responsiveness, ease at which the control is achieved. This is different from severity. Severity is intrinsic intensity before you treat. Control is after you treat, what are the treatment goals? So I was part of, again, this group of the American Academy for the development of teaching the slide set for difficult asthma. So this is where I slide. Now, we had an ICMR funding. We looked at what are the factors, and one of the most important is gene polymorphisms of ADAM33. And we took about nearly 1,000 subjects, 503 asthmatics and 486 normal subjects. And we found that one of the gene polymorphisms, we looked at about 35 different gene polymorphisms, and one of them was associated with treatment responsiveness. We did a haplotype analysis with a smaller number of these subjects. And if you look at the improvement, whereas the rest of the cases, it is more than 400 ml improvement after 3 months of treatment, here it is only about 111. Now, how many met criteria for normal lung functions when we followed GINA guidelines? Nearly half the patients lung of treatment, and that begs the question, how efficient or how good is the guidelines? We need it to get better. We looked at whether the duration of asthma, less than 5 years or more than 5 years, it does not make a difference. There are people inherently less treatment responsive. There are people, even after 30 years, you treat them appropriately, highly treatment responsive. So there is something inherent responsible. Does severity of asthma affect? Absolutely, it does. After 3 months of treatment, 70% of moderate persistent asthmatic did not reach normal lung function. 94% of severe persistent asthmatic did not reach normal lung function. So that's very, very important. We did a cluster analysis based on this treatment responsiveness. It was a 6-month follow-up study. We got about 4 different clusters. We found that 2 of the clusters, even after 6 months, did not reach normal lung functions. Because of lack of time, I'm not going into the details, but we looked at a whole lot of different variables and how they are different from one another in doing this cluster analysis. Important point for the clinician, it takes roughly 2 to 3 months for the patient to reach their maximum lung function. That's when you start to decide on reduce their medicine requirement. All the factors that we included. What happens after 6 months of treatment? These are the different clusters. This is the different GINA-based stepwise treatment that I have shown you in the earlier slide. And again, what happens? How do these people change over a period of 6 months? Again, due to lack of time, I'm not going to go into the details of this. So these are the 4 that found, and based on this Ig level that was important and lung functions, we got about 4 clusters. So the first cluster was milder and younger and atopic and early onset, whereas the second and third that did not reach normal lung functions, this was in 10 to 14-year-old group, and this is a much older group. We did the cluster analysis by adding to the spirometry and the host of clinical parameters that you have seen, impulse oscillometry. And then we now had a more refined phenotyping. We had about 5 different clusters. Again, these are the different clusters due to, again, lack of time, not going into the details of each of these. We looked at small airway resistance, and we looked at the lung functions to categorize these different clusters. Now, this is how the clusters are distributed. The people, even with low BMI, we had one group with very severe, very low lung functions. And this group also, sorry, this did not have a low BMI. This group had a very high, these were obese, and they had very high resistance. So in one, we had, when we added one more tool, we had 5 distinct clusters. We need to look at the pathobiology of poor treatment responsiveness, so the guidelines can be better. 3 possible reasons. Again, we have worked on all these different. The poor treatment responsiveness. Now, again, this work we did with the group, Dr. Rajan from IICB Calcutta. We verified mononuclear cells, and we looked at normal people. We looked at asthmatics who have treated less than 1 year and treated more than 5 years. Now, for the steroid to act, it has to go into the cell, bind to the steroid receptor. This has to enter the nucleus, bind to the glucocorticoid responsive element, and then you have release of or synthesis of compound, and it also suppresses the synthesis of pro-inflammatory compound. This is how steroids act. But this transfer into the nucleus happens only if steroid binds to glucocorticoid receptor alpha. If it binds to glucocorticoid receptor beta, this does not go into the cell. It does not have the effect of steroid. So what happens to glucocorticoid receptor beta when we treat? That GR beta increases with duration of the disease and duration of treatment. This could be one of the mechanisms why there is steroid resistance. They need more and more drugs over a period of time to get better. We also looked at airway remodeling, and I wrote this editorial in 2013 for the ICMR journal. And the other one, of course, is Indians as compared to the Western population. So this was a study by Lang, looked at almost about 20 to 40-year follow-up. 36% of our subjects could have had smaller lungs, then whatever you do, their lung function does not become normal. And what about asthma prevention? Which patients with allergic rhinitis will develop asthma? That's an important point. What is the time interval we have? With the onset of asthma, now, unfortunately, when you want to look at asthma prevention with immunotherapy takes time to act. And once the patient has rhinitis, if you see within 2 years, almost 60 to 80% will develop asthma. So the time interval for you to use immunotherapy after rhinitis has happened is it's very low. So this again we published in about 2009, and we looked at the most important factor here is a sensitization to house dust mite is a risk factor for the development of asthma in a patient with allergic rhinitis. If they use nasal steroids, they are protected from developing asthma. That's important to know. So there are different asthma phenotypes. Again, due to lack of time, I won't go into all those details. It's just for you to get a breadth of what kind of research we are looking into this asthma. We have just started doing pheno. We are already looking at sputum and peripheral eosinophils. Very difficult for us in India, at least, to study the mast, study the mucus characteristics. Maybe we'll have more details, but this is so-called type 2 asthma. It has a specific set of cytokines. It can be without eosinophils as well. So everything type 2 high asthma is not only eosinophilic asthma, it's a whole list of other factors. These are the different subgroups or clusters in this. Then you have type 2 low asthma. So again, these people are obese, they have metabolic syndrome, they have neutrophilic inflammation. Please don't forget how you can reverse the neutrophilic inflammation. But even with all that, some patients do have only neutrophilic, and then you have to maybe look at long-term azithromycin as the only treatment, main choice. They don't respond to steroids. High dose inhaled steroids, oral steroids also may need to be used in different clusters. And if you look at the development and progression of asthma, you find there is a whole different world out there, and how to bring in the guideline, to bring all these features into the guideline and make it simple for a clinician to understand is a challenge that the guideline developers and thank you very much.
Thank you, Dr. Mahesh. It was a wonderful coverage of the topic. We're very thankful for participating in our IMA webinar series. I'm sure you answered quite a lot of questions relevant to the asthma care during pandemic. Any questions? People, I request members to put it in the chat box. We'll take up and we'll discuss with Dr. Mahesh. He's one other person who has done an extraordinary research with respect to the food allergy and asthma and related pulmonology issues from India. As his title suggested, close to about 200 publication is not an easy thing sitting at Mysore JSS Medical College. Possibly, you look at these kind of presentations from people from national institutions like AIIMS-PJ. It's been extraordinary work you have done, Dr. Mahesh, actually. Now, looking at
Thank you.
Asthma requirement in COVID times, I really want to really bring it to the attention. Maybe we need to discuss. We don't know whether we can really ask the best question to you, but we can also bring out actually concern with respect to people have worry about whether to go for treatment or not, whether it worsens problem or not. There is concern about people using inhaled steroids itself during COVID time. Actually, is there any concern about using them?
No, I just discussed about what is the guidelines. When an asthmatic uses an inhaled steroid, his risk of severe disease is reduced. His risk of getting COVID is reduced. His risk of going to ICU is reduced. His risk of needing for mechanical ventilation is reduced. Systematic reviews. It is a combination of multiple studies, not a single study. The only thing we did not show that the risk of death was not reduced. But getting COVID disease, getting severe COVID, getting hospital admission, getting ICU admission, need for mechanical ventilation, lower in asthmatics using inhaled steroids as compared to asthmatics who are not inhaled as the general population. As I said, cyclosinide itself has an anti-COVID effect, right? It acts on PAC1. It's a critical protein in the COVID-19 virus, and it's one of the main therapeutic drug target. So cyclosinide does that. Other steroids do it to a lesser extent. And therefore, instead of using oral steroids, use it for a short burst and then manage with inhaled steroids. But every asthmatic, I would advise, please continue inhaled steroids. This is going to reduce your risk of getting COVID infection also. How does it do that? COVID enters the airway epithelial. How does it enter? it enters through the ACE receptor. Now, people who use inhaled steroids regularly, see, the ACE receptor is reduced. Once that is reduced, the door for viral entry is reduced. And therefore, the risk of getting COVID is therefore reduced in patients with asthmatic using inhaled steroids. They must use.
Okay.
There are no
Question in the
studies
chat
to
box.
know what happens to a normal person using inhaled steroids. There are no studies, unfortunately.
In older, hard than using firewoods. That time you could expect more and more risk factor for asthma. Do you think now it has come down after using gas stoves?
Absolutely. I have no doubt is one of our core area. Mainly, of course, we have been looking at biomass and COPD. We have been doing a lot of work. We have even done 40 cytokine studies. Now we are doing sputum induction. So this is our area of research. And biomass, critically important for developing COPD. But when an asthmatic is exposed to biomass, obviously their asthma gets worse. There is no doubt. It is one of the indoor air pollutants that triggers an asthma attack. Fortunately,
It is already existing.
yeah. Already there is a lot of data like biomass increases the prevalence of asthma, increases the risk of asthma acute attacks. So that is clear. So switching over to LPG makes a big difference. But if you look at asthma prevalence, again, we have done studies looking at urban children and rural children. Fortunately, the rural asthma prevalence is lower than urban asthma prevalence. Physically active. That is
People talk much about cow dung and dupe and all that. Do you think it is also harmful, isn't it?
Cow dung is critical. Again, we have done endotoxin studies in cow dung. If it's about 2005, we went to each of the village houses and collected the dust. They don't have any flooring there. They just use cow dung. Now, cow dung is rich in what we call as endotoxin. See, one patient gets asthma, it will trigger an asthma attack. But in the normal people, when they are exposed to endotoxin, it binds to the toll-like receptors and regulates the immune homeostasis from moving to either autoimmune pathway or an allergic pathway. The Th1 remains Th1, does not move into either extremes of Th1 or extremes of Th2. And these are the benign bacteria. They are not pathogenic bacteria. These are the benign bacteria. And the rural endotoxin is 3 to 4 times higher. If you look at our study, which we published in a US journal in 2005-06, you will find that rural house dust has much richer in endotoxin. Rural children have much less asthma. Rural, they have much less sensitization as well. So cow dung is beneficial, I am convinced. But how to bring cow dung to an urban home, that's the difficult part. And if you go to this rural home, you will find it's not only just the cow dung, it is contact with these animals. The people are lying on top. It's just a single room where they cook, and the animals are below. On top of that, just wooden plank made of bamboo, and the family sleeps on that on top. And the cow is also inside. Otherwise, they keep it outside. Somebody may steal. They keep it inside in a one-room house. So it's a close contact with large animals. Small animals have not shown to be that effective, like dog or cat. Not shown to be that effective or protective. If you're looking at asthma prevention, large animals, farm animals, they have been shown to be protective. But how do you get someone in Bangalore flat to keep a cow inside the house is the question.
Okay, thank you. Dr. Mahesh, there's a question in the chat box.
Yes.
Systemic steroids are biologicals in asthmatic COVID-19 patients.
See, systemic steroids, we all know, has proven to reduce mortality that severe degree. They need, please go for using the systemic steroid. The maximum data has come from Dexona, and that's what you would use for 5 days. I would prefer not to use for 5 days. Now, biologic are very expensive, 20,000 rupees at least per month. For the mepozolimab or Pepilo, it is about 60 or 75 a month. Patients, at least in Mysore, they cannot afford these biologics. Now, biologics are steroid sparing, there is no doubt. But once the patient has got COVID and he is acute, he is admitted, you have to use Dexona. That there is no doubt. Biologics are only used once a month. Biologics are not treatment for COVID. The patient is an asthmatic, he is taking biologic, there is no issue. But in severe, he may need, he is in the ICU, Dexona is your first choice. I hope that's answered your question.
Okay, there is one more question. You can check at the chat box actually.
Yeah, which steroid inhalation is best for asthma control? Again, we did this study, first with a 3-month study, then we did a 6-month study. We compared beclomethasone, budesonide, and fluticasone. All 3 steroids are same. You can use whichever one you prefer. We only found that fluticasone gave a small edge in the first 15 days of treatment. By 30th day of treatment, it didn't matter which inhaled steroid you use, all are same. Cyclosinide is slightly less potent than the other 3 inhaled steroids. Otherwise, all are effective. There is no issue. An asthmatic on long time usage of Seroflow develops loss of taste. How to manage? Preferably in these patients, you can use cyclosinide. As I said, cyclosinide is activated by an enzyme present only in the lung. So patient has got a lot of taste, dysphonia, oral candidiasis, all these local side effects. You can manage. Now, cyclosinide is activated to an active steroid molecule only in the lung. Therefore, none of the oral effects you are going to find with cyclosinide. That's it.
They are more fun for depression. It's already asthmatic, again steroid, depression.
Great connection, Eliappa.
And what is the, yeah.
For a short course of steroids, you usually see steroids generally, again, it's a very small proportion. We have seen steroid psychosis, but it can come with 1 or 2 doses of especially the parenteral steroids. Fortunately, with COVID, we have not seen that many. COVID is more likely to cause depression other than of steroids per se. 5 days of Dexona is not going to increase the risk of anxiety or depression. Whatever happens is more likely because of the COVID disease. If anybody sees the news, they will have all the anxiety and depression.
Dr. Karunakar, is there any question or shall we end the session?
So basically, I would like to reiterate Dr. Mahesh's observation that practically asthmatic patients are not at increased risk of COVID-related morbidity. That's one of the important things. But Dr. Mahesh, I want to ask one thing, like, is there any special precaution the asthmatic have to take?
Except using the regular medicine, they follow all the precautions like from the general population.
Okay, otherwise it's all fine, right? And one thing I wanted to ask you now, like say post-COVID, because one of the things in the COVID patients is that post-COVID syndrome is a concern. In that respect, have you come across increased risk of asthma in these patients?
See, once there is lung fibrosis, once the fibrocyte starts coming in, and people respond differently. You find the CT score is 20 and they will not have any COVID sequelae. You find CT score is 4 and they will have COVID sequelae. You not find a very good correlation. There is some correlation, but not absolute correlation. Even mild COVID people can come up with post-COVID sequelae. And once there is fibrosis, you will always find that the patients will not feel normal. See, lung is like a rubber band. It stretches with every breath. Now, once the compliance reduces, the work of breathing to every breath is more. It's like you walk with 2 kgs stop walking, but you can't stop breathing. So once the interstitial thickening starts happening, now always these people will have a problem. And some of these patients, like it is any viral infections, they are one of the triggers of these asthma genes. Not only due to COVID, we have seen it with respiratory syncytial virus, adenovirus. So you name the in some patients can trigger off the asthma gene and first time, and then after lifelong they will suffer from asthma. We have found that with COVID infections also. Post-COVID, we have had typical after 2 months or 3 months, we do lung functions in these patients and demonstrated that they have asthma. It's not as common as lung fibrosis. Interstitial fibrosis is quite common, and that reduces oxygen transfer. And one of the issue that was discussed in the last talk was the use of pulse oximeter. Very important. Use pulse oximeter at exercise. Look at the difference between exercise and rest. So you find pulse oximeter is 96. The child or anybody walks up a flight of stairs, it remains 96. They're doing well. 6. One time of stairs, it drops to 86. Now this child or adult has to go to the hospital. It's going to get worse quickly. So the exercise challenge and what happens to exercise, the drop in oxygen saturation is a good indicator of interstitial thickening, or due to edema, or due to fibrosis, or due to any other reason, or the cells, inflammatory cells that will come in. Whatever is the reason, the drop in saturation or your gas exchanging membrane thickening, alveolar-capillary membrane thickening. So anybody who has a drop in saturation on exercise must go to the hospital. That's a key point that you can use.
Thank you so much. There's one question in the chat box. Maybe we can, that should be the last one.
Any change in treatment with asthmatic patient?
With the pregnancy.
Treatment change, we manage asthma as it is. Even with pregnancy, all these drugs are safe. Even montelukast is also now in category B. All the generally budesonide, I'm sure other steroids are also safe, but a lot of clinical studies has happened with budesonide. So budesonide is in category B. Other inhaled steroids are in category C. But I'm sure they are as safe. But if you really want to go that looks at, reads up and asks you questions, then go with budesonide for the patient. That's in category B. You can use the LABA, you can use salbutamol, levosalbutamol. They're all in category B. No issues.
Thank you, sir. Thank you, Mahesh, sir, for that wonderful presentation. It was very informative. Now,
Thank you.
may I request Dr. Prasad, sir, to go ahead with the vote of thanks.
On behalf of IMA KSP, I thank our eminent speakers for today, Dr. Lalita AV, who covered the topic on severe COVID-19 infections in children. So we had a very wonderful session, and with all the illustrations by her. Thank you, Dr. Lalita, for this wonderful session and the insights what we are given. We will be taking it forward. Thank you. And I immensely thank Dr. Mahesh from Mysore. He's a professor of pulmonary medicine from JSS Medical College. I thank you for all the guidelines and also the practical tips you have given for the clinicians on asthma management, and also especially COVID-19 and asthma. I thank you very much for clearing so many doubts on asthma as well as COVID-19 and the association of environmental allergens and asthma also. And I thank our IMA KSP President, Dr. M. Venkatachalamurthy, who is a constant source of encouragement for all these academic activities which is going on, especially our webinar series on COVID-19 and children. I thank our President-elect, Dr. Suresh Kudva, and also Dr. Shukumar Lakol, who is there with us for their encouragement for these academic sessions. I thank the chairman of our subcommittee, who is doing a lot of academic activities, Dr. Harish Vidilante Bhattu, for all his constant encouragement and also the involvement in all our academic activities of IMA KSB. I thank Dr. Karnakar, BP Karnakar, our honorary treasurer, as well as he is the man behind this mission COVID-19, which is the webinar series going on from IMA KSB for the last 5 to 6 weeks, and it will be taken forward. I thank him for all the arrangements. I thank all our senior members of IMA, Dr. Geeta, Dr. Vijay Kumar, and our immediate past president, Dr. Madhusudan Karaganur, who was there with us, among us, and also many of the pediatricians from Bangalore as well as from all over Karnataka who joined us, either in this Zoom platform as well as for the YouTube also. I thank all the delegates, all the doctors from all over Karnataka who have joined and made this academic feast a very grand success. Though it is late, we never realized that already it is 2.5 hours now we started the program. I thank one and all on behalf of IMA KSP. I thank you. And also I thank our digital manager, Mr. John, who is there. Thank you, one and all. Happy good night. Thank you.
Good night. Very nice.
Thank you.
Good night. Good night.
Good night. Thank you.
Thank you, Dr. Lalita, Dr. Mahesh, and everyone. Thank you so much.
Thank
I also thank Dr.